All right, so we are in our second lecture in the psych series, and I gotta be honest with you. I'm not really sure if this should have been on the psychiatry side of things or the neurology side of things, but it's about consciousness and specifically disorders of consciousness. Now, disorders of consciousness has a pretty well established, laid out physical, basis. But the question of subjective consciousness has always been a very controversial topic, and we're going to try to touch very barely on this and mostly save this for a future lecture from a philosophical standpoint. But I think that this it is placed well after our sleep lecture and before thinking a little more critically about subjective states, just as a framework going forward. And so this right here, these are our learning objectives. You can pause the video and review them if you wish. And as always, we're going to start with a little bit of a historical background. So consciousness, at least from a Western context, the idea really largely initially started from Aristotle in terms of like writing about this. He wrote something called De Anima, which means on the soul. This kind of defines the psyche as bringing life to the biological body and seeing the soul, which is seen synonymously with the psyche as not really being a substance, but rather a function of the body. And then, flash forward to the 1600s, Descartes really split the mind-body notion with this dualistic notion of thinking about, basically a thinking substance as distinct from the body and linked it, this intersection between the mind and the body through supposedly the pineal gland. Of course, even to this day, we still see the split, meaning the body with neurology and the mind with psychiatry. And so it's something that we still have trouble putting together. By the 19th century, John Hewlings Jackson, who just was one of the founding, neurologists of modern neurology, developed a hierarchical organization that basically states that the lower brain centers control the reflexes and the higher brain centers control consciousness, with lesions along this leading to release of lower levels, proposing a possible way that the brain and mind can be intertwined. Then, by 1949 or so, the duo of Morosi and Magoon basically discovered what's now known as the ascending reticular activating system, which was the first neural substrate of wakefulness. From a psychological standpoint, just a little after Watson and Skinner discovered behaviorism, which kind of temporarily, discouraged further study of consciousness in terms of like kind of replacing it and focusing on more observable behavior. And it took a little while for this interest in consciousness to be revived with cognitive science, but that eventually led to computational models of understanding. And so, in the 21st century, we defined the default mode network and network neuroscience, predictive models, and things like that. And the default mode network, specifically by Marcus Raichle, um, provided more of a functional understanding of the self-referential thought process, which we've basically paired with consciousness. And then Carl Friston in 2005 uh, basically developed these ideas of predictive coding and the free energy principle, which described the brain as a prediction machine that aims to minimize uncertainty and actually feel more comfortable with predictability. And in the modern day, also, there's philosophical aspects, such as what's called the hard problem of consciousness, which is this question of at what point does subjectivity arise from, these objective things that we see, these nodes and organic aspects of the brain, at what point do they become metaphysical? And so this is obviously more of a Western perspective of dualism, introspection, hyper rationalism. And so from the Eastern side of things, there's other, way different ways to see this, as not really seeing consciousness as an ego or an independent entity, but rather just two sides of the same coin. Meaning that basically maybe all of reality, the ultimate reality, is one consciousness, which is considered Brahman. And we are just one view or one perspective of that consciousness, just one vector, which is called the Atman. And Buddhism, of course, sort of, came out of Hinduism, so to speak. And so there's some different and similar notions to this. But they also have a notion of what's called an Atman or no self, which kind of basically refuses the existence of a permanent self. And that awareness or consciousness, also called Vijnana, is a mental force that animates the body, which can be reflected upon through mindfulness. More nature-oriented views of consciousness, such as through Taoism, is that consciousness is basically just harmony with nature as an effortless flow or wu wei, with an emphasis on balancing between attention and awareness. There's also mystical states of consciousness and transcultural, commonalities between a lot of these sort of mystical belief systems like Sufism, Kabbalism, Christian mysticism, etc., which describe the subjective experience as being transcendent and yet associated with unity and timelessness and a global connection to which may include a divine entity as well, as being more personal, intimate, and not from a first person perspective rather than a third person perspective. Also, to put in light some more modern views too, the psychedelic states have promoted a lot of these similar mystical states of consciousness with these themes of unity, timelessness, and transcendence. And these have been associated with a desynchronization of the default mode network, which would be basically a breakdown in the neuroanatomical ego, which might actually shed some light on the underlying biology of these states that are described in so many mystical traditions. So, how, for our sake, how do we define what consciousness is? There's a lot of philosophical tangents that we can get into it, but the most important thing, really, just at least from a pragmatic stance, is that it basically can be divided into two dimensions: arousal and awareness. Arousal describes the level of consciousness, meaning, are they awake or are they asleep, like our last lecture? While the second part, meaning awareness, describes what's present in consciousness. So this is going to be the content of the experience. Disorders of consciousness, as we're going to discuss in the next slide, is actually going to be a spectrum. Basically, when we're fully conscious, we are awake and we are aware. But in the next issue of consciousness here, which is called the minimally conscious state, which is kind of one step down, we're awake, but we're only mildly aware. When we're not aware at all, but we are awake, then that's what's called unaware wakefulness syndrome. It used to be called a vegetative state, but of course, it's not a very PC thing to refer to people as vegetables, so understandably, it's called UWS. And then when we're not awake and we're not aware, then that's a coma. So we're comatose. And then some related terms here too. Just to really, really be nitty-gritty with our definitions, attention is defined as a selective focus to a specific stimuli. Awareness is the subjective integration of attended information into self-experience. And consciousness is the overarching state making attention and awareness possible. And some uh, clinical conditions that are loosely sort of related, but not really within, the umbrella term of disorders of consciousness is locked-in syndrome, catatonia, and delirium, which we'll touch on along the course of these series. So this is how I like to think of disorders of consciousness overall as kind of the spectrum, ranging from not awake, not aware, coma to awake and minimally aware, which is the minimally conscious state, with the bridging point in between as the unaware wakefulness syndrome. And so, with this in mind, consciousness isn't really a binary thing. It's not are you conscious or are you conscious or are you not? It's more of a continuum of states, which relate to, varying degrees of arousal and awareness, with and each of these things actually have their own mechanism, which we're going to talk about as we go on. And consciousness is difficult because it can also be qualitatively different. Because awareness, motivation, volition can all be selectively impaired, and so that's kind of important as we go on. And so these in terms of like motivation, those are related syndromes under the terms of disorders of diminished motivation, like abulia and akinetic mutism, which we can talk about, in a different lecture. But for the sake of our lecture, we really want to focus on coma, unaware wakefulness syndrome, and the minimally conscious state, with some of the pathophys down there. But we're going to talk about in just a little bit. And I guess for the sake of completeness here. Maybe it's important to maybe touch a little bit on these related states. So catatonia is not really disorders of consciousness, but rather a disorder of agency, or as we're going to talk in a different lecture, really a motivational movement disorder of sorts. But you still have retained arousal and awareness, so it doesn't fit within this bucket. Delirium, which we're actually going to talk in our next lecture, is a disorder of fluctuating attention and awareness. So even though attention and awareness are affected, it's in a fluctuating manner, so it doesn't really fit into the disorders of consciousness bucket. And then locked-in syndrome, it's very sad, but it's complete paralysis. But as we know, there's preserved consciousness and cognition, so alertness and likely awareness. And so it doesn't truly fit into this disorders of consciousness bucket. So it's important for us to, get into the more concrete neuroanatomy here, specifically with that ascending reticular activating system that was discovered. So it's mostly located in the pons and the midbrain tegmentum, and there's all kinds of nuclei involved in basically maintaining wakefulness, which we sort of introduced in the last lecture on sleeping. But here we have the nuclei more laid out in this chart here on the left. And so I'm just going to be calling it the ARIS from now on. But the ARIS is basically, having inputs from the hypothalamus and the basal forebrain prior to projecting through these thalamic nuclei, which are the intralaminar and the midline thalamic nuclei, with the thalamic nuclei on these charts here. And basically, the thalamus works to amplify and synchronize oscillatory activity within this ARIS system. As we've seen in our previous lecture, the thalamus is involved in synchronizing all kinds of, sleep spindles and all these EEG findings that we find in sleep, and it also works in a similar fashion when we're awake as well. And from the thalamus, these projections go on towards the cortex. And then the cortex, of course, integrates information into a meaningful experience. And so, some clinical sort of perspectives to consider here is what would it look like if this whole ERA system is off? I would imagine the patient would be comatose because then they are not alert. And if you're not alert, you can't be aware. If it's dysregulated or inconsistently on, there's no continuous reliable anything. And so that's more consistent with delirium. But if the Eris is on, but disconnected from the motor output, then that's what we call locked-in syndrome. Because the ARIS is still functioning, they're still alert, and they're still able to be aware, but it's not connected to their motor system. And catatonia is sometimes it can be considered a psychomotor locked-in syndrome, but it's a very different beast, which we're going to cover in its own lecture. Um, so to talk about the thalamus in a little more detail, it's really, its role as a central relay and integrator. It has all these nuclei that we see here on the left. And it's thought to generate these thalamocortical loops, which generate rhythmic oscillations in like the alpha, beta, and gamma frequencies. And those function to synchronize different cortical regions that we commonly see as different frequencies on the EEG, as we've discussed before. So during wakefulness, these oscillations are like super fast, like 30 to 80 hertz, and this enables rapid communication while in sleep, these oscillations are way slower, like down to the delta range. And that's when consciousness basically fades away. So the transition between these rhythms correspond to different levels of consciousness. A thought here is that consciousness arises when thalamocortical loops achieve sufficient synchrony and complexity to sustain global integration. There's been a theoretical model made around this idea, which is called the Global Neuronal Workspace, or GNW, which kind of proposes that the thalamus selectively amplifies data through thalamocortical synchrony, and this enters the sort of workspace of conscious awareness. So the thalamus basically gates sensory experience from reaching consciousness, or allows certain sensory experiences to enter consciousness. And it's also thought to just overall select what arises to consciousness through this mechanism by balancing bottom-up sensory data with top-down cortical data. And these sort of hierarchical loops achieve their coherence, and when they do, then that's what enters conscious awareness. I know a lot of this stuff is very, very abstract, but it's usually right to think of the thalamus as working as a sort of bodyguard or serving a gating function of some kind of what comes into our own conscious awareness. And this model depends more on connectivity rather than the integrity of any single structure, since everything here is kind of interconnected. And of course, we can't really talk about consciousness and awareness without discussing the default mode network. The default mode network is kind of seen as a sort of neuroanatomical ego, and might be the reason why we have a sense of self. And the DMN generates top-down priors about the world and ourselves. And through the connections that it's getting from all that bottom-up sensory data from the iris and from the thalamus and all these emotional systems, the DMN actually interacts with this and provides top-down regulation with the help of predictive processing, with its connection with the hippocampus and then screened by the thalamus. This leads to the sensation of what the thalamus allows, to enter into conscious awareness. And this is one thought of how awareness is felt, which is a combination of not only arousal, but also self-related integration. So the DMN provides a sense of also like temporal continuity, the sense that your I is persisting through time, and disruption in this connectivity would lead to a transient loss of the autobiographical self. And so, we can see this in delirium when there isn't a consistent, thalamic synchrony, but we can also see this in neurodegenerative disorders like Alzheimer's. So we can see it in psychedelic experiences, and occasions with like depersonalization and derealization when even the sense of self isn't really remembered. Um, and so it's kind of, as a general exercise, we can look through these nodes in this chart in the bottom of the screen here, and see how specific nodes of the default mode network have specific functions and how they are associated to, clinical manifestations. And so, in normal wakefulness states, you have a stable sense of self, and this whole system is synchronized, and we're good. When, somebody enters anesthesia or gets general anesthesia, then there's a desynchronization of all of this, and there's a loss of self-awareness. During REM sleep and dreaming, as we talked about in the last lecture, there's a reactivation of the default mode network, but it's not 100%, the same way as when it's awake, but it's very similar. And so you get this internal world without the executive control from the cortex. In unaware wakefulness syndrome, it's thought that there's no self-related processing. And so you're not fully aware of things. And it's possibly due to a lack of this like, very crucial connectivity, while in minimally conscious state, there's a partial reactivation. And so there's maybe a fragmented awareness. Um, in psychedelic states, for example, there might be actually a hyperconnectivity sometimes. And then other times there could be a full disintegration, which is what we see in like, colloquial ego death experiences. And then in meditation, there could also be a deactivation with global coherence. So there's sort of a non-dual awareness that's thought to happen in very intense meditators. Okay, so active inference is a very important thing to know. It's this idea that when the brain is generating predictions about the future, it's probably generating a lot of predictions. So, like, let's say there's like 100 predictions that are being predicted based on your expectations, your beliefs, your self models, and just your overall experiences. You can't be predicting that so many different things are going to happen with only one thing. So you kind of have to filter out all of those predictions. And one way that the brain filters this out is through what's called active inference. So active inference uses bottom-up information, sensory information from the world that we're getting that's being screened and gated through the thalamus to basically match and screen out the top-down sort of predictions that the brain is making that is unlikely to happen based on the here and now. And so only when we can screen out sufficient predictions, it's thought that it's only then that the thalamus allows us to basically be aware of, maybe an option. If there's, two or three possibilities and you have to make a choice, then it's thought that basically those choices come into our conscious awareness. And so the reason the brain does all this is because it basically wants to minimize what's called prediction error, also known as free energy from Carl Friston. And what this says is basically that the brain doesn't like to be surprised. If the brain has to defend itself in an unexpected way, it would like to know, before it has to, because it's way harder for you to, cure something than prevent something. So the brain's always trying to prevent excess energy utilization over time. And so, which, we colloquially call surprise. And so the ARAS system is actually very heavily involved in this. And not only does it maintain alertness, but it also maintains this integration between the thalamus and the outside world, negating what's coming to our conscious awareness. And that's all, kind of checked by our own sense of self through the machinery of the default mode network, which maintains the awareness of the brain's model of self in the world. All right. So, this kind of relates to neuropsychiatry. So, I do want to talk about just some neuropsychiatric disorders that this is important in. So with in schizophrenia or psychosis overall, it's thought that these predictions might be over precise, and the ability for the brain to correct those predictions is just not very good. And so these overconfident or kind of chaotic priors can't really be overridden by bottom-up inputs or the active inference that we talked about. And so that can lead or manifest into delusions and hallucinations. While in depression, there also might be overly rigid self-predictive models, but those are coming from an association that we know in depression, which is a hyperactive default mode network, which may not be as malleable to that bottom-up input. So even though that's kind of it sounds sort of similar to psychosis, it's very, very different because it's related to a hyperactive default mode network rather than just like an unstable salience network, which we're actually going to talk about in our very next lecture, which is on delirium and psychosis. And then, in anxiety, a lot of that prediction might be biased towards threat, and one may be hypervigilant. Of course, we kind of talked a little bit about delirium, that there might be not as much, that there might be fluctuations in awareness and disrupted precision in delirium. While in psychedelic and mystical states, there might be a temporary loosening of high-level priors. This is what Robert Carhart Harris calls, in his Rebus model of how psychedelics possibly work, that there's a broadened perceptual flexibility, meaning that basically there's less bottom-up active inference going on. And basically, so that top-down data can just be flooded without, with a lack of rigid priors, which is sort of the opposite of what we see in depression, which, it might be one of the ways that we think that psychedelics might help with depression as well, but only one of many ways. Okay, so to talk about attention specifically, attention, of course, like we said, there's attention and awareness when it comes to consciousness. So let's start with attention first. Attention is basically the transition from arousal to selective awareness. So you must already be alert to attend. And once you're alert and you attend, once you provide your awareness and direct it to something, that's what attention is. And that's the ability to orient, focus, and sustain consciousness on a meaningful target. And so all the coordination of this involves three different systems. It starts with the alerting system, which is the ARAS that we already talked about. Like we already said, these are ascending projections from the locus coeruleus and the basal forebrain and all those neurotransmitter-rich nuclei that's going to maintain cortical alertness. This system also modulates like signal to noise, meaning that it basically tries to narrow your focus into a narrower target rather than take in too much. If you do end up taking too much, then that's more consistent with like anxiety and hypervigilance states. If you take in too little, then that actually might be like a very rigid selective bias that we tend to see with like depression and things like that. Um, so that's the alerting system, which is basically just the ARAS system. The orienting system involves more cortical stuff. So you have your frontal eye fields, which is part of your anterior attention networks, and you have your parietal system, which is your posterior attention networks, and they work together to guide both, directing eye movements with that anterior attention network, and also with an idea of like spatial coordination as well. And so this helps direct attention to, some external salient target, or which would be, externally driven attention. But we can also have endogenous or internally driven attention based on our own motivations, desires, planning, which would be like a goal or task-oriented stimulus. And so clinically here, what's relevant is that strokes that affect the parietal lobe can lead to hemispatial neglect. which actually inhibit this orienting system from working. And so this is a pretty like striking example of unconscious unawareness, despite having intact vision. Because that orienting system isn't working, and so that leads to neglect in the context of parietal strokes. And then finally, there's an executive control system, which again is also cortical, and this involves more the central executive network, predominantly the dorsolateral prefrontal cortex, which maintains working memory and task rules. It has very strong connections with the anterior cingulate cortex, which monitor conflicts and errors. And then lower down, we have the basal ganglia, which gates cognitive and motor output. And then we have the SMA, or the supplementary motor area, which links the intention to action with a sense of agency, along with motor planning before actually doing the motor task. And so this is a very delicate system, and it working really, really well is basically the neurobasis of volition and executive function, which gives consciousness its sense of directedness. The salience network is really important too. No, we're not really talking about it in detail. This is going to be discussed ad nauseum in the next lecture. But it's composed of the anterior insula and dorsal anterior cingulate cortex, and it functions to detect and prioritize salient stimuli, whether it's internal or external, so we can direct attention. And so when something's salient, the salience network suppresses the default mode network and activates the central executive network. This number three, this executive control system can actually work. And then when that happens, it directs your attention to whatever the stimuli is. Um, and it also helps integrate meaningful signals to decide whether something is relevant to the self or not, which means that it's going to switch back to the default mode network if needed to do that integrative work. And so the clinical sort of relevance with the salience network, just to allude a little bit to the next lecture, is that when that salience network is not working, which is a heavily dopaminergic network, there's an impairment in switching between internal and external focus. So we see that in ADHD, we see that in schizophrenia, we see that in depression, and we see that with frontal temporal dementia as well. If your salience network is overactive, then you would be sort of hypervigilant, anxious. And if the salience network is underactive, then there's not much of that dopaminergic reactivity to things, and so you might feel apathetic, amotivated, and unresponsive. And so, which the latter you see in disorders of diminished motivation. And so, while we talk about all this, it's also really, really important to always keep in mind that the thalamus is coordinating the synchronization of these attention networks, and it can amplify these networks through gamma synchronization between visual areas. And it can also help in the narrowing of focus by suppressing irrelevant input outwards, this kind of selective ignorance. And so we can kind of narrow down your attention to a direction. And so damage to the thalamus, like from some kind of subcortical stroke or something like that, can lead to a very distractible patient, or with loss of selective awareness. And also parts of like the posterior thalamus. We have the pulvinar and reticular nuclei, which its activity can actually predict attention shifts before the activation of the cortex in functional imaging studies. And so this demonstrates kind of a cortical, like a subcortical to cortical bridge to attention and awareness. I know we talked about quite a lot, but this is, just like a summary of some of the clinical stuff that we've mentioned so far, because I know, I definitely said a lot here so far. Um, so some of the clinical relevance here is, of course, we start with diagnosis, which is always with the history. The history is, might be very, very limited if the patient can't talk to you. And so if somebody is completely comatose. Obviously, there's not going to be much of a history that we can get, and it will be more through chart review, collateral, and things like that. But we can, always see certain things, even if the patient isn't talking. Like, if is there really no motor output, or is there any like eye movement? Are their eyes, if you just look at them, are their eyes like open or closed? Do they seem to tend or direct their attention at all to you? Is that alertness and awareness fluctuating? Like, are they delirious? Is there like a toxic metabolic encephalopathy or something like that going on? Is there a psychomotor element? Um, or like a functional unresponsiveness? Like, is there any reason to think of like catatonia or dissociation, or anything in between? And so just by looking at the patient, you get a lot of information, but of course we also have to examine them as well. So after observation, and seeing if there's any behaviors that they elicit spontaneously, um, we can see, we can actually actively examine them. So like if you talk to them, is there any response? Do they respond to voice or pain, to touch or noxious? Do they have any sleep-wake cycles? If you ask like the nurses if this is like an inpatient or something like that, is there any arousal at all? So if there's no arousal at all, then maybe they're comatose. If there's at least eye opening, but they don't really seem to be aware that you're there, maybe it's like an unaware wakefulness syndrome. If there's some purposeful behavior or tracking, but they're not completely all the way there, then maybe at least they're minimally conscious. Goal-directed behaviors are going to be really important to see if they can make any. Can they follow commands? Are they visually tracking objects? Is there any neglect in their neuro exam? Are their purposeful movements consistently like reproducible, or is it just chance? Are they doing things reflexively? And speaking of reflexes too, we should check those. So let's check, especially if this is like a TBI sort of case, you want to check their brainstem reflexes, so pupillary, corneal, oculocephalic, gag, cough. So those are five brainstem reflexes right there. Is there any triple flexion? Um, which of course, these things aren't really linked to like awareness or anything like that, but it's just to give us some data of how their brain is doing, especially their brainstem and spinal cord. And from a completely different view, if they elicit any kind of catatonic signs, then we can do the Bush-Francis, the BFCRS, which we're going to discuss in its own catatonia lecture. Um, and then there's some scales that we can do. I hardly ever do them personally, but they might be helpful. Like the Glasgow Coma Scale is here on the bottom right, if you find that helpful. Um, and then eventually, we're gonna get some labs like right off the bat, like toxic metabolic labs. Think like basic serum studies like electrolytes, hepatic, renal, thyroid panels, ammonia, B12, thiamine, HIV, syphilis, Lyme, the whole gamut. Some urine studies if that's possible. You might need catheterization, but you can get like a UA and UTOX, maybe some drug levels if that's relevant. We want to rule out any comorbid substance use, or benzos, opioids, maybe seizure medications if they look like they possibly seized. Um, but also, if there's any psych history, maybe known or unknown, you might just get lithium levels. Consider like serotonin syndrome if they're like hyperreflexic, maybe an anticholinergic toxicity if the phenotype warrants it. And then, depending on this, you can get a little more advanced, maybe like an LP or, to rule out infectious autoimmune paraneoplastic stuff. But the LP would only be after you get neuroimaging. By the time you saw them, I would imagine that they would have gotten at least a non-con head CT to rule out, any major structural abnormalities or bleed. And then I would imagine by the time you're seeing them, the question that you're really asking yourself is like, should you get an MRI or not? An MRI could be really helpful in trauma if that's the reason that they have disorders of consciousness, because you can see anoxic brain injury, diffuse axonal injury. You can confirm if there's an ischemic stroke or not, demyelination, gliosis, microhemorrhages. Maybe there's a specific pattern of atrophy that could be helpful, or hydrocephalus. And so most of the time we get an MRI, and we would do that before the LP, of course, if the LP is warranted. And then The EEG will, of course, be extremely important to see not only if there's seizure activity, which should be the first thing that we should try to, rule out, but also we can find other things that are coming from the thalamus, like we talked about. Like are there preserved sleep architectures and sleep-wake cycles? Is there something to make you think that there's an encephalopathic state? Like sometimes we see triphasics on the EEG. And you can also see if the patient is reactive to stimuli. So the EEG can be more helpful than just determining, like seizure or not seizure. Um, Here, there isn't, I gotta be honest with you, I want to add a slide of meds to every lecture, but there aren't really good meds for disorders of consciousness, even though we use amantadine, very often, but that's more for TBI, which is going to be a different lecture. But I thought, given the fact that the ARS system has so many different neurotransmitters, I just made this chart that you can go over in your own time, or if you want to pause the video, just to go through a review of what each neurotransmitter is doing, where it's coming from, and how it can be helpful to kind of have an idea of what it's doing dynamically. And I also, like to talk about therapy with each clinical lecture. Of course, how can you do therapy with somebody who might be unconscious? Likely not. But I still think that there's some interesting things to note here. So, you know, these what we talked about here with the neurotransmitters, this is more bottom up stuff. Therapy tends to be more top down, and that's how, both would modify consciousness. And of course, there's not much literature on psychotherapies for disorders of consciousness. But here are some that I thought were kind of interesting, and there actually is some data for. So, music therapy and familiar voice exposure is something that's been looked at. I have some references on my notes if you download this slide. But music therapy is exactly what it sounds like, just structured music or emotionally salient sounds. They've been found to increase cortical and limbic activation, even in patients with minimal responsiveness. That was from 2013. And there's also some EEG and fMRI data to show that preserved right temporal and limbic activation during personally relevant music is a thing that could happen. And it's not, just all music, it's more for personally relevant music, which is kind of interesting. And that might allude to some connectivity with the DMN being intact. And then there's like enhanced frontal parietal activation and increase functional connectivity with familiar music, familiar voices. It's always good, not only in disorders of consciousness, but also with delirium and patients with dementia. It's always helpful to have familiar faces and voices and meaningful things around them to kind of as a means to ground them and to comfort them through a very distressing time. And then effective touch, naming, familiar voices. This kind of works similar. I guess in a fancy way, that could trigger limbic thalamic synchrony, but it's also just nice. And narrative reorientation therapy is kind of an interesting one. This is autobiographical storytelling. So it's kind of like, I don't actually know how this really looks like because I haven't seen it, but I would imagine that this could even include like family members telling their loved ones stories about themselves and kind of reactivating memories in that way. I have some studies on the lecture notes here if you want to download and review that in your own time. But this is sort of just like my conclusion, sort of overview slide with a lot of the conditions that we talked about, and along with some overlap as well. Um, so, we can pause and review this in your own time. Some of the things that I think are kind of interesting here and might not be explicitly stated is knowing like lesion localization. So basically, that could lead to a difference of issues like, whether it's depression, abulia, or akinetic mutism. That could actually all look like psychomotor slowing. But if you have bilateral, cingulate cortex lesions, then maybe you might think more the abulia akinetic mutism area. But then depression can also happen. Depression and apathy can happen from damages to like basal ganglia, mesial frontal areas as well. There's stroke-related depression, which is going to be its own lecture. And depression can also lead to like profound psychomotor slowing that can almost look like a disorder of consciousness in very severe cases. They might also have catatonic features from pretty severe depression, especially if there's like a psychotic addition to that, like depression with psychotic features. And then delirium is probably the most common thing that we see in the hospital all the time. And so we want to make sure that they're not on like anticholinergics or anything that's thought to worsen delirium. And of course, disorders of attention is going to be really important in this lecture with ADHD. But also, we see that we can't think that neglect is not part of that system as well for our patients with likely right hemispheric strokes affecting the parietal cortex. And so, in conclusion, consciousness is complicated, but it's likely a manifestation of these very dynamic interactions among the iris, thalamus, and cortical networks. And understanding these dynamics can help bridge, neurology and psychiatry. And I still don't know if this lecture should have been in the neurology section or the psychiatry section. But as you know, and you probably noticed, I've made a lot of references to a lot of lectures to come. And so I think this is going to be more the foundation for the next lectures, which are going to be way more oriented to psychiatry. Here are my references, and thank you so much.